Hello and welcome to EuroPCR Daily News with Angela Ferrara and Dejan Milasinovic and myself, Vanessa C. Stone. This is the place to come every day for the hot takes on what's gone on during the day at EuroPCR, but also for the latest insights into key topics in interventional cardiovascular medicine from some of the leaders in the field. Now, today we have William Wines in the studio with us just a bit later to talk about the We Care initiative. We're also covering World Hypertension Day with Felix Mahfoud, and we will be looking into news of a late-breaking trial. But first, to plunge you straight into the atmosphere of the first day of EuroPCR 2022, we went out to meet some of the participants. Well, it's the opening day of EuroPCR 2022, and we're most definitely back. The atmosphere here at the Palais des Congrès in Paris is buzzing with the excitement of the cause, obviously, but there's definitely something special about this year. We're back in person, and there's a special sort of joy in the air as people meet up, sometimes for the first time in several years. Just to give you an idea of the size of the event this year, we're covering 3,753 square meters here at Porte-Maillot. There are 735 presenters and 685 faculty members, all presenting 315 sessions. And of course, there's the excitement of the brand new EuroPCR Plus program for you, our viewers. Much more than just recording of the in-person event, EuroPCR Plus is a full digital course running side by side with the event here in Paris. We had our first live cases at the very start of the day today, and of course tens of special sessions running simultaneously throughout the day, both in person and online.
I think some key fundamental framework from a fellow's perspective, I think it's really important that we get that early on and we're able to train with the right tools and the right mindset. So really hoping to get that here.
And some of the fellows are here for the very first time, meeting up with their mentors and with their peers. Okay, now we've scheduled a quick chat with Judith Andreka, and she's participating in this fellows course, and she's just over here. Judith, hello.
Hello, nice to meet you.
Nice to meet you. Tell me, where have you come from?
From Hungary.
Okay, and is this your first time at EuroPCR?
Yes, exactly. This is my first time.
So, how's it going?
It's incredible. I'm just really enjoying being here in France, in Paris, and it's an incredible opportunity for me to be here as a young interventionalist, and I just really honored, honestly.
Excellent. You've just followed a fellows course session on acute coronary syndrome, I think, and high bleeding risk. Is that right? So is there one particular thing that you've learned this morning that you think you will take back to Hungary and apply in your hospital?
Yes. For me, the main take-home message was that you always need to think about your patient like an individual, because every patient is different, and every patient has different characteristics according to their coronary settings and also according to their high bleeding risk or the bleeding risk at all. So you always need to think about the patient. So it's really important. It's not new, I mean, usually at home we are thinking like that, but you need to focus every time when you are doing an intervention after that how you treat your patient.
Great. So that's for the learning. What about networking opportunities? When you meet up with people, do you talk about techniques? Do you talk about complications?
Of course, we talk about these, which you mentioned, but we also talk about different, like different techniques or what they are usually do in their cath labs. For me, it's really interesting to see how different countries, different cath labs working, because there are not big differences but slight differences, and I think it's also this networking is especially good because we can exchange our experiences, and I can learn or we can learn from each other, and it's really incredible.
Excellent. Well, thank you very much and enjoy the rest of the course.
Thank you very much.
It was great to see the enthusiasm. And now, for a particularly difficult task, Dejan and Angela have had to choose their top takeaways from today. Now, with days as rich and busy as days at PCR, it's quite a challenge. But so, Dejan, what have you got for us for this first day of the course?
First of all, thank you very much. Daily News is a place to be at this time of the day if you want to find out what's happening at EuroPCR 2022 and you're not in Paris. Many have joined us in Paris, but some are not here. And for you online, please be here, and we are going to discuss what has been happening throughout the day. So let me first tackle this pretty difficult task to choose 3 points that Angela and myself consider to be important throughout the day. So I'll start with the first one. It is about the left main. So you see here, it is the left main wrist stenosis. That never happens. We do our perfect interventions, but in reality it does. And there was a really interesting session today with the topic of how to treat these patients and how to tackle wrist stenosis. So what you see here is a case presented during this session by Dr. Salvatella, and it was about the left main a patient with a left main disease, and you could see there was a really nice result, and you see it on the right-hand side of the slide, on the stent-enhanced techniques in our cath labs, where you see very nicely expanded stent and the intervention was finished with a kissing balloon inflation. So you would say a perfect result, a very good treated patient, and what's going to happen next? After 4 months, you see the same patient with unstable angina, and what happened is there was a wrist stenosis of the circumflex ostium. So this was treated with another stent, a DES, in a culotte strategy. What is the takeaway? Why did we show this? The takeaway is when we treat the left mains, one of the points that are the weakest point in our treatment strategy is the ostium of the circumflex. So whichever technique we try to use to treat these patients, we really need to pay a close attention to the ostium of the circumflex, even in patients where we did not stent it, as here was the case. So provisional strategy is used in the majority of the patients, but it will not solve in some of the patients the problem of the ostium of the circumflex. So that was the first point that we wanted to bring up to you, not in Paris, as a session that really was interesting today. The second is calcified lesions. We see more and more patients, as Angela also knows, throughout the day, which are frail, which are also older, and who also have calcified lesions in their coronary arteries. So how do we approach these lesions is the question. And there is a series of sessions about this particular topic at EuroPCR 2022. This session was particularly interesting to me. It was a recorded case from the crew in Aalst, and it was commented by Professor Emanuele Barbato. And what I thought were very good 2 points that, at least for me, were the take-home messages of this session. The first was, we need to understand the morphology of the calcified plaque. And you see it here, the case, and this is really from that session. You see the case. This was a patient who had undergone CABG previously and also has artificial valve, and it also has a pacemaker lead and a really complex-looking left main stenosis. Now, when you do OCT in this patient, what you can see are different plaque morphologies of the calcified lesion. What you see here on OCT is actually a calcified nodule. But on the above picture, it has not yet penetrated the intima. You see a really thin intima overlaying the calcified nodule. And then on the bottom OCT image, you do see the calcified nodule protruding into the lumen. Also, not to forget, 5 to 6% of our ACS patients will be caused by protruding calcified nodule, and we know this from the post-mortem studies. So it is an important etiology of the ACS as well. So that was the first point for calcified lesions. Understand the morphology of the plaque. Why? because it will dictate your strategy in terms of the percutaneous treatment. And here's a very nice algorithm developed by Professor Babato. And I can already reveal a secret for you, our online audience. Tomorrow, you will have the chance to see this entire session with Professor Babato, who is going to be talking about this very specific algorithm and who is going to be explaining how to apply this algorithm to treat our patients with calcified lesions. As you can see, it is based on the lesion crossability and whether you're able to advance the imaging catheter, and if yes, then you decide on the device that you're going to use based on the morphology that you find. And then the third point, and this is the last point, and I think it clearly says on the slide, do not forget tricuspid valve disease. And I think this is maybe the main message, at least for me, because left main and calcified lesions, we know that as our challenges. We know that we need to be careful about those interventions, and we all try to develop strategies for them. However, tricuspid valve disease is something which is not so present in the minds of interventional cardiologists around the world. So what I would suggest is that at least those who are available, to those whose the session is available, to visit the learning session developed by Professor Maizano about the tricuspid disease. And the 2 points that I took as especially important from that session is the fact that, of course, we know it all, but I think it's important to reiterate, most of the tricuspid disease patients that we are going to see are going to be functional secondary tricuspid regurgitation, and it's even roughly 5% in patients who are more than 75-year-olds, in many heart failure patients, in many atrial fibrillation patients. What are the percutaneous answers to tricuspid regurgitation? There are many. And that is, I think, the main message from this session. You need to be aware that now already there exist many solutions to percutaneously treat these patients, and that is very important to match your device with your patient. And I guess that the first steps are made here at PCR, where you can go to the learning sessions and really find out about these important developments. So I think that was it for today, for the takeaways. We'll have the additional for tomorrow. Thank you.
Well, thank you very much for the presentation, Dejan. Thanks to both of you for the selection, which was clearly the difficult part. And now it's time for us to meet our first guest. William Wines is here to discuss the We Care initiative. Hello, William, and over to you, Dejan.
Yes, so thank you very much for being here with us, Professor Wines. Angela and myself, we have been thinking about how to shape this interview and what to ask you. One of the questions that we had is, throughout the day, we talk to each other as interventionalists, as doctors. We treat the patients, but we also need to talk to the patients. So what is the We Care initiative? What does it stand for? What does it aim for?
Well, thanks for having me, and congratulations on your beautiful studio. Now, We Care is a generic word for advocacy. We can rely on our experience with the implementation of primary PCI for STEMI, the Stent Save a Life program. What we've learned is that if we want to achieve our goals, we need to get out of the cath lab, at least some of us, and get the society, the healthcare providers, all the stakeholders of this chain of events engaged in order to improve access of patients to our life-saving procedures. And that's what the Stent Save a Life program has done beautifully well. Actually, on the next slide, if you advance it for me, is sort of a summary of the amazing track record of this advocacy program. And basically, it started some nearly 14 years ago, has expanded over 35 countries. We know exactly how to make it work, engage a country champion, and also help them with tools. There is, for instance, a blueprint that is a methodological guide that helps local, national societies to actually set up an efficient regional, national STEMI care pathway. And actually we can be, I think, as a community, very proud of it, because what people said will never work, to bring acute MI patients to the cath lab in the middle of the night, is now happening throughout Europe and also internationally. So that advocacy program is now moving primarily to low and mid-income countries, but focusing on Africa. The leadership has been taken over by Dr. Thomas Alexander and Dr. Jan Peek. Thomas has worked in India a lot. He has developed a model of hub and spoke hospitals that can treat patients according to what's available where they're hit by DMI and then transferred as needed. So that is Stand Save Alive. Now, at that time, we didn't have COVID. But we've learned a lot from this. And based on this track record, we said we have to do something about COVID. Because during, of course, major problems, patients were not treated, particularly acute MI patients, but also high-risk TAVI patients were postponed. We've seen the consequences of that, inadequate care or even zero care, lack of care. And we want to get prepared for, the post-COVID. And that's why we launched this additional advocacy program that is called We Care. So it's a long answer to a short question.
Thank you for that. I think it's more clear now, at least to me. One of the questions is, what is the outreach? What is the desired outreach? Who do we focus on with these initiatives?
Okay, so We Care is actually developing in 3 stages. And again, it's based on the good practices that we've learned from the STEMI, engaging local, national colleagues who are the champions of the project, but also then reach out to the public, to the patients, to patients' organizations, to healthcare providers, insurance companies, and even higher up, politicians. Okay? Now, we have strong message for them. And the message is that we know the consequences of what has been brutal care removal. There was care. We remove it. It was removed because, unpreparedness of the system, because overwhelming by, patients with COVID who needed treatment, nurses taken out of the cath lab, etc., etc. We know the story. So based on that, we have developed actually a project that will develop in 3 phases. The first phase is, we consider done already, actually since a year. It was about creating global awareness about the issues. Okay, the fact that it can't be that you stop and remove care from one day to the other. We need to have a list of diseases that we cannot stop taking care of, and it's not just cardiovascular, it's the same for cancer, right? Okay, phase 2 is moving from there to local awareness, and that's exactly where we are at the moment. Okay, that is, according to our processes, engaging national, local representatives who are going to go to their minister, to their hospital administration, and tell them, listen, something needs to happen. We need to have nurses. We need to have a plan. We need to be prepared should we face another crisis. We need to have a list of diseases from which, that we need to continue to treat whatever happens. And we're actually also speaking already to European Union and seeking funding for that project that will then go into phase 3, which is implementation of the prevention and preparedness program.
Thank you very much. So basically, the global outreach is something which is known for EuroPCR, and myself included, many people around the world have benefited from the global outreach of EuroPCR style education. So I asked Angela, what was her main takeaway this year, given that many people came back? So how do you see it?
I'm very happy to come back in Paris. A lot of people came back in Paris, but I think that the digital platform, with the digital platform, we are everywhere. So this is the great issue.
So I think that's a good point. We are everywhere here in Paris, but also everywhere on the digital platform. Professor Weiss, thank you very much.
Thank you.
And thank you, William. You're free to go. So thank you very much for that.
Excellent.
And today is World Hypertension Day. First celebrated back in 2005, its general aim is to raise awareness. Now, we have a special guest coming to tell us about it in detail. But first of all, Diane, What is the focus this year?
Yeah, that's my question as well. We are interventionalists, so we are not used to talking about hypertension if it's not on a shift in a ward or in an ambulance. So I will just right away ask Felix, can you tell us why is this important for us? Why we interventionalists should care about hypertension?
We have very good reasons to care for hypertension. It remains the most frequent risk factor causing premature death. It's relatively easy to diagnose, it's easy to be treated, but 25 of all patients, only 25 of all patients reach blood pressure targets. So there is a huge room for improvement, and we as the interventional community, we have to improve outcomes, particularly in patients with hypertension.
Okay, and Angela, did you have a question about specific what has been done in this field?
For the Hypertension Day, what does it mean for interventional cardiologists?
It's actually a day that has been created to communicate on the seriousness of the disease and to advocate new treatments and correct diagnosis, appropriate diagnosis and treatment of patients with uncontrolled blood pressure. And we have established treatments such as lifestyle modification and antihypertensive drugs. They work very well, but most of the patients don't frequently take them. That's a huge problem. We know that up to 50% of all hypertensive individuals are not taking the prescribed medication. So there is obviously an unmet need for new treatment modalities, and among them is a device-based approach, which is renal denervation.
That's actually what we're really much interested about. So can you tell us what is at the moment the phase of development of renal denervation, and how do you see the current flow and where it goes?
Absolutely. So we have now, in the second generation of randomized sham-controlled trials, proven in 5 independent studies that this technology, this approach, lowers blood pressure in patients with no concomitant antihypertensive medication, but also in patients on 1, 2, or 3 drugs, so the so-called resistant hypertensive individuals. We showed that it lowers blood pressure not only acutely, but even progressively over time. Up to 3 years, we have seen progressive reductions in blood pressure with meaningful values of up to 20 millimeters of mercury in 24-hour systolic blood pressure. And that should translate into improved outcomes in these individuals at risk. So we're developing this as, I think, as a third pillar of hypertension treatment. Besides, and of course, in most patients, we still require lifestyle modification, antihypertensive drugs, but devices, and particularly renal denervation, may represent a third adjunctive treatment modality for some patients, particularly for patients with uncontrolled high blood pressure at risk.
For many of our colleagues, including myself, this is something new, and we're not doing it routinely in our practice. So one of the questions is, basically, can we count on renal denervation to decrease dependency on drugs, or do we see synergistic effects? Because you just said that over time, the effect evolves, and that there could be an effect in 3 years that maybe we did not expect at the beginning, so that patient could go off drugs at some point?
That's a very good question, and it's very important when you discuss this approach with patients that you set expectations beforehand. So this technology should not be used to get patients off medication, but we should use it to get patients to blood pressure control. And again, we have a lot of patients that do not reach society-recommended blood pressure targets. So many patients would require additional treatments, and here, in combination with drugs and lifestyle modifications, there's an additional, you said it, an adjunctive blood pressure lowering being documented, and that may help a lot of patients with uncontrolled blood pressure.
And the final question, what are the next steps? You mentioned that you may be aiming now for the outcomes, not to show that we can lower the blood pressure with the devices now, but that we can improve outcomes as well. What outcomes do you have in mind?
So we looked into the Global Simplicity Registry, the largest database available so far, with more than 3,000 patients enrolled. We presented it here today at the late-breaking clinical trial session, where we documented an improvement in time and therapeutic range, and you'll hear more about it with the next discussant. But what we are showing here for the first time is that this translates into improvements in outcome: less stroke, less myocardial infarction, less MACE, And hopefully that will then translate into a pickup of the procedure in clinical practice.
Thank you very much, Felix. What I would like to remind everybody is that you are going to have one more opportunity to speak on the digital channel, and it will be on Friday. So maybe then you'll reveal more about the effect of this device therapies on outcomes in hypertension patients.
Absolutely.
Thank you very much.
Thank you.
Thank you.
Thank you, Felix Mahfoud. You are free to go. I know you have a session to get to. Now, late-breaking trials are, of course, an essential part of EuroPCR. And we wanted to highlight one that is particularly relevant to today's edition of Daily News. So, as we promised at the start of the programme, we have news of a late-breaking trial for you from Andrew Sharp, who has just got here. Hello, Andrew.
Hi.
Hi.
Nice to be here.
Dan.
Hello.
Hi.
Well, thank you for joining us. Angela and myself are very much looking forward to your presentation. It's going to be a brief one.
Yes.
So just so that
Extremely
our
brief.
digital audience knows, late-breaking trial presentations are much longer than here. Here, we want to know the answer to two questions. Why was this study performed?
Yes.
And what are the key results?
Well, thank you very much for the opportunity. I mean, it follows on from what Professor Mahfoud was just saying to you, that there is a big unmet need in hypertension. And there's two major clinical programs that have positive sham control evidence now. We have the Medtronic program with their spiral device, and we have the RECORE program with the Radiance device. So we had data from both programs today at the same session. And Felix has just explained to you about the time in target that Dr. Kanzari presented. I'm going to talk briefly about the Radiance program, which was a pooled patient-level analysis of patients who were within the solo and the trio study. So I'll just tell you a little bit about the Radiance device for those who aren't familiar. You can do denervation either with radiofrequency, which is the Medtronic device, or with ultrasound, which is the RECORE device. So the RECORE ultrasound device is what we presented data on today. And it's a different mechanism. It denervates proximally within the renal arteries, and it does so from 3 short 7-second energy activations in the proximal left and proximal right renal arteries, plus or minus accessory vessels if we have them. And it's able to denervate patients in a way that's been shown to be positive in the Radiance Solo trial and the Radiance Trio trial, which were 2 prior presented trials that were published in The Lancet in 2018, 2021. What we did was we put the patient data together and analyzed them so we could get a feel for whether this is a generic effect of the device with or without medicines. So if I can just go on to show you what we found. So the first is that if you'd had denervation with the RECORE device, you had a blood pressure reduction of about 6 to 8 millimeters of mercury over and above sham. And then after 2 months, we started adding medications in. And so we looked at what happened at 6 months. How many extra medicines did you need in order to reach control? And if you'd had the denervation, you had about 0.4 fewer medicines. That doesn't sound like that much. But in the trio arm, where patients had 3 drugs to start with, the 4th drug was spironolactone, which is a potent drug with a lot of side effects that patients don't like in hypertension. About half of them will stop taking it if they're prescribed it. And in the solo arm, we had the 1st drug added in because patients began that trial off drugs. They had 1 drug added in. That's normally the most potent antihypertensive drug is the first one. So a 0.4 reduction in drug burden after denervation is an important thing. And when you look at what happened at 6 months, when you look at the addition of drugs to renal denervation, you see when you adjust for baseline blood pressure number of drugs, you still see a separation of about 5 millimeters of ambulatory systolic blood pressure, which is an important difference. It doesn't sound like much, but actually you'd expect that to reduce stroke rates by a quarter, heart failure rates by a quarter, and heart attacks by about a fifth. So if that had been achieved with salt reduction, weight loss, exercise, amlodipine, candesartan, whatever drugs we choose, we'd expect about a 1/4 reduction in MACE. So what we've proven in this study today is that whether you start on 0 drugs and then you have denervation and add in medicines, whether you start on 3 drugs and add in spironolactone, which is a powerful but poorly tolerated drug, then you get still a maintenance of denervation effect. And so we've now proven that drugs plus denervation or denervation plus drugs, they all maintain an advantage for the denervation arm. That's the key. Some people just said, well, if you just give drugs, the denervation effect will fall away. We've shown today that that's not the case.
That's a very important finding. Thank you very much for that. And one question, we have a minute to go.
Yes.
How do you see these results fit into the puzzle of the development of the device-based therapies for these patients?
Well, these data are now patients on 0 drugs, patients on 3 drugs. So you've got newly diagnosed hypertensives who are perhaps intolerant of drugs. We've shown that denervation added on will help them. And then we've got the resistant group. If you're on 3 drugs and you're not at control, adding denervation on helps them. And you are more likely to be at control if you had denervation added on to 3 drugs. So I think just like the message you heard from Felix, this is part of a treatment package. It's not a cure for hypertension. It is part of the treatment package now. You start with lifestyle, you try drugs. If drugs aren't working or aren't tolerated, denervation's part of that package.
Thank you very much. Thank you very much for this. I think with this we will close today's news session. It is great to see you. It will be even more nice to see you tomorrow. We have seen today on the digital channel something about imaging. We've learned what's new in CTO PCI, what's new in bifurcation PCIs. We have revisited renal denervation, have seen what impact it makes. So see you tomorrow.
See you tomorrow.
See you. Bye. Ciao.